Hello, it's Dr. Jeffrey DeSarbo again, and welcome to NeuroSeries Episode 8 on the neurobiology of body image. This component of body image, distortions and distress, is something that goes with most people who have eating disorders. Although it's important for me to kind of say it's not everybody who has that. Even people with anorexia sometimes can have more accurate perceptions of what they see when they look in the mirror compared to others who just have a tremendously distorted perception. And body image is often something that is, they use the term an undue influence on the person of how they think and how they function during the day and the moods they go through. Let's get started. So, one of the things with often comes up in treatment is should a person weigh themselves? Should they not weigh themselves? And there's a lot of different thoughts on this. The thing with these studies that show is there's an increased behavior for people to want to weigh themselves when they have different types of eating disorders. Of course, anorexia nervosa, people weigh themselves the most frequently. Bulimia nervosa is second, and binge eating disorders third. Sometimes this almost obsession and compulsion to have to weigh themselves can be, 20, 30 times a day. For others, it might be daily, and yet for others, it might be a few times a day. The thing is, when I'm working with patients, I prefer, especially when an eating disorder is in more of an acute stage, I like them to stay off the scale. I kind of say, the scale is a tricky thing. It's when you wake up in the morning and you're about to step on the scale, it's almost never a good outcome. People, if with a certain types of eating disorders, if the number's up, it might be a disastrous day, and the moods are already set where one person is going to be very anxious, depressed, and sad and angry through the whole day. And if the weight goes down, sometimes people are upset with that too, that they're not maintaining weight. Even though the other part of their eating disorder head is kind of happy about it, they know that that might lead to difficulties in their treatment process with their clinical teams. So that question of self-weighing, is it helpful, is it harmful for psychological well-being? They did a kind of a study of a lot of different research papers that were published on it. And generally speaking, most of those studies showed that it's not helpful, that weighing oneself does cause more emotional harm and psychological issues during the course of the day than weighing oneself. Different treatment providers have different approaches. Some want the patient to be aware of their weight because sooner or later they're going to see it, hear it. They may go to a doctor's office who says it, and they want to prepare them for that reaction. But other providers, especially in the first parts of treatment, when in that acute phase where things are really bad, I want a patient to be able to wake up in the morning and get out of bed and decide if it's a good or bad day without looking at a number on a scale. So there's different approaches to it. Generally speaking, usually want my patients on my end to take that scale and put it away. Let the nutritionist, the doctor, the therapist probably shouldn't be the person handling it, but the nutritionist and the doctors can follow the patient's weight and kind of handle discussions with them about that. Now, when one looks in the mirror, when we're talking about body image, they're usually seeing this distorted image. And a lot of people used to always say, and maybe some still do, they think they have this diagnosis of BDD, or body dysmorphic disorder, which is really not the proper term to be used in the case of an eating disorder. Generally speaking, with an eating disorder, one looks in the mirror, they see this distorted image. And that's not with everyone, like I said, but it can be with many, if not most people who are going through an eating disorder. There's also a second component to this body image, which is their distress levels that go with it. So some may have a distorted image, and on a scale of 0 to 10 have a rate their distress at a 5, and others may say my distress is 10 out of 10. And have very difficulty just functioning or thinking or doing anything during the course of the day. What I'm usually saying is when a person looks in the mirror, though, it's interesting because what they're kind of seeing when a person has an eating disorder is not just the body. They're looking at the entire person on both the inside and the outside. So that self-judgment they make from the image they see is usually based on the whole totality of their individuality, although they're not consciously looking at it that way. Another thing that's kind of important is when a person looks in a mirror, they often see things. There's parts of the brain looking in a mirror that if someone looks at a photograph, they judge their body differently. And that's because looking at a reflective live image is kind of processed a little differently in the brain than looking at a photograph. And sometimes in treatment, we'll use that to help people try to get a better representation of what are they seeing when they look in the mirror. Now, I'm going to get to why this distortion happens so that clinicians, families, and patients have a better idea. We discuss one of the aspects of the neurobiological findings when someone goes through an eating disorder is changes in blood flow. And in this study right here, it looked at people who had this distorted body image with anorexia nervosa. And they noticed this unique pattern to the medial temporal lobes of the brains where it kind of resembled what people saw in psychotic delusional types of orders. Now, that doesn't mean that somebody with an eating disorder who has a distorted image is necessarily psychotic, but it does have the blood flow pattern that creates this, in a way, delusional representation of what they see when they're looking at themselves in a mirror. So one looks in a mirror and they say, oh my God, I look huge like, an African elephant. And other people around them will then say things like, well, but you're not. Why are you being so dramatic? Or why are you making things up? It's like, and when one person says that to somebody with an eating disorder who actually sees this representation in themselves as being larger than they actually are, it kind of causes that individual to shut down. Like some people don't even trust the opinions of others who may make comments like that, or they feel you don't get me, you don't see what's going on, and it kind of creates more distance with loved ones who are kind of not understanding why this is happening. So to me, I'm always trying to help families understand that someone looks in a mirror who's anorexic and says, I'm huge. That is their reality. That is what they're seeing, and that's what they're feeling as well. Now, the one thing that goes on, we always talk about the ed voice. When people are thinking about food, weight, calories, exercise, and always body image is one thing that's there's constant thoughts about how one feels and how one looks to others. That's why there's a lot of social isolation that takes place. People don't want to go out with their friends. They don't want to go to the stores, go to work, go to school, be seen in public. Now, in studies such as this one right here, it kind of shows that these constant thoughts at times are caused by regions of the brain, and they refer to that become neuronally vulnerable. So there's problems with the communications and the networking processing in these circled regions. Again, I don't have to name them, but just to show you there are very specific findings in the brain when people look at these types of studies. And when you have these compromise in these regions of the brain, one will start to develop this distressing internal preoccupation with their own body and how they look. And it's something that's now running in the brain, and it interferes with their ability to pay attention to things on the outside, like external stimuli, things that are happening or going on around them. And so a lot of people are often saying, I'm very distracted. I think I have ADHD. I can't focus on things. And a lot of that is those eating disorder thoughts, and especially when it relates to body image. And so it causes problems with focus and attention and concentration and things like work, school, interpersonal relationships. And one is just completely involved with this intrusive thoughts that keep going on and on with self-judgment that are always negative. And again, that's where distress comes, and no one else can see it except the person who's experiencing it. This is just an interesting study. It looked at the brain hemispheres and body image distortions, especially as it relates to left and right-handedness. And in this study, it showed that people who have a strong right-handedness have a significantly increase in their discrepancy between like actual reports of their BMI versus what they perceive is their body shape and body image. So it's just interesting that if you're left or right-handed, I'm not saying that that is something that makes somebody develop a strong distortion of body image. But this study kind of then shows what they find is like with other studies as well, that there's different types of processing that's decreased, especially in the right cerebral hemisphere of the brain. So that's kind of how what you see in studies like this with handedness. So there are different types of brain functioning that can cause more people to have a stronger, more disturbing interpretation of their self-image and their body image, while others who may have more of a mixed-handedness or left-handedness may not necessarily experience the same degree of body image distortion and body image distress. And that's a general conclusion and everything, nothing to completely define one's level of potential body image distress. This is another study that I think is very interesting. It's one that I talk about. I think I spoke about it early on some of the different types of examples of studies that we find in the neuroscience of eating disorders. This again goes back to different parts of the brain where they see there's a decreased cellular volume present in people with eating disorders, especially anorexia nervosa, compared to healthy controls. And amongst these regions, there's regions in the parietal lobe that have been found to have a significant decrease in cellular volume that directly correlates to a person's drive for thinness. And I think I mentioned, but it's always worth repeating, this is very important that if somebody with anorexia starts to restore some weight, what they are restoring is cellular volume as well. And if the process kind of hits a roadblock and starts going backwards and a person is losing weight, they can lose that cellular volume again. So if one is prone to losing cellular volume in these regions of the brain, let's say the region of the parietal lobe, and they restore weight in a treatment facility or in an outpatient program where they worked really hard to restore that weight, and then at some point their head says, I think I overshot that mark and I need to just drop a few pounds, maybe it's 5 pounds. They will drop those cellular connections, the volume in those parts of the brains, along with any other type of body mass they may lose. And as they lose that, the drive again gets stronger to continue to seek that drive for thinness. So it's very crucial that when a person does restore weight, they try to maintain that. And I'm always going to say a minimum of a year, where, it takes usually, 6 months for neurons to start connecting and working properly again, and a year for it to kind of set in concrete so they run better. So you usually don't want to see, when people have restored weight, any decrease in weight loss, especially during that first year, because relapse can be very high. This is more regions of the brain, and another study that just shows that there's cellular volume loss in these regions that are associated with body dissatisfaction and drive for thinness. The superior temporal gyrus, the medial temporal gyrus are both regions of the brain that across the board can start to have decreased cellular volume. And the up top, the superior frontal and the medial frontal gyrus, they when you adjust for weight and BMI, they also seem to have that cellular volume loss. So it isn't like, that's what I was saying. There's so many studies that show different parts of the brain and regions that can be affected that I wouldn't want anyone to say, well, you lose a little bit of weight and now your drive is increased. You must have cellular volume loss in the parietal lobe or something. Not necessarily. This is just different things happen in different people, but I'm just trying to give you a broad overview of some of the changes that seem to account for some of the results and behaviors that take place. A lot of times people ask me, well, should we then go maybe get an MRI? And I'm usually saying no for several reasons. One is it's probably never going to get covered from insurance or anything. And even if we know why, let's say I can tell someone's cellular volume in the parietal lobe and some of those other regions is lower than it should be, then it was restored with weight gain, now it's low again. It doesn't change the treatment necessarily. The only thing it does sometimes help is a patient understanding that there are these actual physical changes to the brain and central nervous system and take place, and that's why recovery is so important. Another study on the amygdala, I know we talked about it when I spoke about binge eating. In this study, it showed, again, the lower volume of cellular connections and everything takes place. That's increased in the amygdala with body image distress and as well as things like phobias and depression. The amygdala, again, one of its primary purpose that everyone thinks about is its fear center. And its fear center is something that really works strongly with eating disorders. In fact, when I go to this next slide here, this was a study that kind of looked at how do male brains and female brains differ in how they process body image, words, images. And it kind of shows, again, with that genetic difference as men tend to process these negative stimuli with unpleasant words for body image using a whole brain kind of process, where females are often, they're using several parts, but a big part that lights up again is that little pink area. That's that amygdala, that fear center. How that plays out clinically is the average length of an eating disorder in a female is about twice as long as it is in a male. And I always think about when I'm sitting in my office, I use this as a broad generalization where I might say, if I have a male sitting and I'm saying, here's the treatment plan, and you're going to do this, and you're going to do this, and you're going to do this, the reaction is a little more laissez-faire, okay, Whereas if I say the same set of instructions to a female patient, it's like the patient is shaking in anxiety. The fear center is clearly lighting up in their brain. Their eyes change, their disposition changes, and it's kind of like the head is shaking, no way am I going to be able to do that. Now, that's a generalization, and it could be completely reversed based on the individual I'm working with. I've had the same exact reaction in male patients, and I've had female patients, although much more rare, that are also able to say, just kind of tell me what to do, and I'm going to try to go ahead and do it. It's never that easy, of course, because in both males and female, that amygdala plays a big role in their treatment. We'll talk a little bit about that when we get to the section on therapy. And I did want to mention that as of now, it's hard to find good research on eating disorders and the lgbtq population. It's some of the very basic studies have shown that there are in males that gay males have a significantly higher rate of eating disorders than heterosexual males, but there doesn't seem to be much difference in the rate of eating disorders in females who may be lesbian, bisexual, or heterosexual. That's today. I think this is a realm that could stand a lot more research, and hopefully that's going to be coming, as well as work with patients who are non-binary and transgender. There's very little information on that, but there is a lot of sometimes the stress that goes with just personal identity, but sexual identity growing up, and keeping something to themselves leads to a lot of distress, a lot of emotional issues. Sometimes coming out brings with it a lot of pain as well. And those types of interactions with people can lead to changes in the brain that may make somebody, again, who's prone to an eating disorder, kind of have that, again, with epigenetics and everything, turn on those genes and develop it. But the research right now is just very limited, and hopefully we'll have more in the years to come. So next I'm going to talk a little bit about in NeuroSeries 9, the neuroscience involved with psychology and therapy and treatment and some ideas and concepts behind it. I hope everybody's going to continue with that, and hopefully you're getting something out of each one of these presentations, and I hope you don't miss any of them. So I do thank you, and I'll see you next in episode 10.